and welcome to Assignment 3 UNISA PC3702. Please like, subscribe, and share. Let's get this party started. Okay, we have old exam questions and answers there. That gives you some insight into what they need us to learn. We're looking at anxiety, OCD, and associated disorders. We're going to be looking at 3 phobias: agoraphobia, specific phobias, and social anxiety disorder. There are also panic disorder, generalized anxiety disorder, separation anxiety disorder, and selective mutism. Then we have obsessive compulsive disorder, body dysmorphic disorder, hair pulling disorder, and skin picking disorder, also called excoriation. Trichotillomania, hair pulling disorder. Duration, we get asked this in the exams. So we've either got 6 months or 1 month. The phobias are all 6 months. Panic disorder and obsessive compulsive disorder, at least 1 month. Generalized anxiety disorder, 6 months. In children, 1 month. For separation anxiety and selective mutism. Anxiety is an adaptation to a threatening and dangerous world. When it goes wrong, you have a disorder. Okay, anxiety symptoms we can split up between emotions, thoughts, behavior, and bodily sensations. Emotions are feelings such as fear, watchfulness, dread, or terror. Cognition are thoughts such as anticipating harm, a feeling that you're going to die, concentration problems, a sense of unreality, and hypervigilance. It's important to know which are which because that's how they catch us out in the exams. Behavior is anything that you do. Okay, so it would include things like freezing or dependent behavior. Somatic symptoms are anything that you feel in your body, that happens in your body. Okay, such as diarrhea, increased heart rate, goosebumps, etc., lightheadedness. Okay, biological causes of anxiety. There are physiological causes such as medication or hypothyroidism. It's associated with the amygdala being overactive. The amygdala is the part of the brain that tells us we are in danger and manages fear. Without an amygdala, you have no fear. It triggers the hypothalamic pituitary adrenal axis, the HPA axis, and also triggers the hippocampus and prefrontal cortex, which is where you assess danger and where also it gets regulated. So then it sends back feedback to the amygdala. Okay, calm down. Genetics, there's definitely a genetic correlation, but on its own, it's not sufficient to explain anxiety. Anxiety does seem to correlate with low serotonin, high childhood stress, low maternal support. Psychological causes for anxiety: cognition, negative appraisal, seeing everything as threatening. Anxiety sensitivity, when you feel your heartbeat, you feel it as a signal to be afraid that there's danger. And feeling lack of control. This is key to all of these disorders. Social and sociocultural dimensions to anxiety. Unsafe environments, trauma tends to affect women more than men, and some cultures more than others. White people in America more than others. Phobias. There's questionnaires, by the way. Okay, phobia is a strong, persistent, or unwarranted fear of a specific thing or situation. There are 3 categories to phobias. Social anxiety, fear of being judged or humiliated by people. or rejected, usually around public speaking or meeting new people. Specific phobia: needles, mice, spiders, rats, dogs, sharks. Agoraphobia: anxiety or fear in situations that cannot be escaped. So there's at least 2 or more of these are needed for a positive diagnosis. A fear of being in a crowd or standing in a line. A fear of using public transport. A fear of being in open spaces. A fear of being in enclosed spaces or being outside of the home alone. Etiology: biological dimension. All phobias show moderate genetic contribution, a heritability of about 30%. There's a more active amygdala. Some seem to be innately predisposed. It's much more difficult to develop a phobia of a pen than a scorpion. This is because of biology. Psychological dimension. Okay, there's fear conditioning. Phobias can be created, often the result of a frightening experience. A dog almost bites you, you may develop a phobia. Observational learning or modeling. Your mom is scared of dogs, you may develop a phobia. Negative informational effects. Too many newspaper articles about people being hurt or killed by dogs, you may develop a phobia. Okay, cognitive processes. Catastrophic thoughts and cognitive distortions. That dog is going to kill me. Can cause phobias to develop and sustain themselves. Now you're conditioning yourself to be afraid, because every time you see that dog, you are more afraid. Social dimension. Overprotective parents. Parents who don't support their children's independence and confidence. So the child doesn't develop emotional regulation and coping skills. Okay? Negative family interactions and stress, being bullied or social conflicts. All right? So lack of control is a trigger for phobias developing. Sociocultural. Women are more likely to have phobias about small creatures like scorpions and a stronger disgust response. Social anxiety, not gender differentiated, but more common in collectivist cultures that use shame, such as Chinese or Arab cultures. Treatments: benzodiazepines and selective serotonin reuptake inhibitors. But more effective than medication is cognitive behavioral therapy. For just about all of these conditions, CBT outperforms medication. Medication can be highly addictive and has side effects. So there's exposure therapy, gradually and slowly increasing exposure without moving into panic. Okay, so gradually increasing exposure. Systematic desensitization. You imagine the thing, okay, and you remain calm. Keep your body calm. So you're teaching your body to become calm. This is also a form of extinction. Systematic desensitization. Cognitive restructuring. Identify harmful, irrational thoughts. That dog is going to kill me. That dog is behind a fence. To helpful ones. Modeling therapy. Very effective. Observing a model, remaining calm in the situation or with the thing. See, that little girl is friends with the dog. Okay. Panic disorders. Panic disorders can feel utterly terrifying. They're very strong sensations, and they send a lot of people to the emergency room of hospitals believing they're having a heart attack or they're going to die. Panic attacks are recurrent and unexpected attacks of fear or terror. So for a panic disorder to be diagnosed, you need to have repeated panic attacks, also a fear of having an attack and what might happen to you during the attack, and then changing your behavior to avoid having another panic attack. for a month or more for positive diagnosis. There are two kinds of panic attacks. Those you can expect because you know your cues and your triggers, and those you don't expect that can happen at any time, that just erupt. Symptoms of panic attacks. All right, so to call it a panic attack, you need at least 4 or more of the following symptoms. And also, of course, the intense fear. Palpitations, pounding heart, accelerated heart rate, sweating, trembling, sensation of shortness of breath or smothering, feelings of choking, chest pain or discomfort, nausea or abdominal distress, feeling dizzy, lightheaded, faint, unsteady, chills or heat sensations, numbness or tingling. When you're really going in overdrive, you will experience that. Derealization, you feel as if you are unreal or as if reality is unreal. Depersonalization, you may not feel like you're in your body. You may be just observing from outside. Fear of losing control or going crazy, and fear of dying. Okay. Biological dimension. The amygdala is definitely involved. So that strong fear means the amygdala. Okay. It is heritable moderately, which is 32%. Serotonin and GABA are both less available. That tells you that which medication is going to help. SSRIs, that's right, Prozac, etc. Okay. Psychological dimension. Catastrophic thoughts that I'm going to die. That really does not help in a panic attack. Sensitivity to anxiety and physiological vigilance. So as soon as you start feeling yourself going into a state of anxiety, you may panic because you're afraid of a panic attack. And conditioning. So the more you have them, the more scary they are, the more you have them. Okay, so triggers are stressful in society, stressful anxiety-provoking social environment. So fear is conditioned. Separation or loss. So that being isolated is very scary. Being bullied or social conflict. Social cultural expression, more common in women. Varied expression, more common in some cultures than others. Treatment. Primary treatments are medication and cognitive behavioral therapy. Okay, the medication helps, but then as soon as you go off it, there's a high chance of relapse. So it works on the amygdala, but it doesn't address real change. For that, you need CBT, which is highly effective. CBT influences the prefrontal cortex and the hippocampus because it helps regulate fear. Okay? It increases self-efficacy as the client gets control of the disorder themselves. So you extinguish with the fear associated with the internal bodily sensations. When I feel my heart racing, I do not need to be afraid. Okay? And extinguishes the fear associated with frightening situations. When I see a needle, I don't need to be afraid. Involve the following steps. Educate about panic disorder, correct misconceptions. You do not have a heart attack. Okay. Identify and correct the catastrophic thinking that is triggering the panic. And teach to self-induce. So this is a form of extinction or desensitization. You teach the person to self-induce the sensations associated with panic in order to extinguish the conditioned response of panic in response to those internal sensations. Also, encouraging the client to sit with the symptoms without responding to them. Teaching coping statements and teaching the client to identify potential triggers before the panic starts. So it's all about gaining control of yourself and the situation. Okay. Generalized anxiety disorder. Characterized by persistent high levels of anxiety and excessive or difficult to control worry accompanied by physical symptoms. So this is long-term and it takes up a lot of time. There's many different thoughts of worry and anxiety that go through a person's mind. So it's not fixated onto one issue necessarily. Okay. In order to be positively diagnosed, symptoms must be present for most days for 6 months and cause difficulty and distress in functioning in everyday life. Also for at least an hour a day. Below that is not qualified as a positive diagnosis for GAD. Okay, it's also associated with 3 or more of the following 6 symptoms: restlessness or feeling keyed up or on edge, being easily fatigued, difficulty concentrating or going blank, irritability, muscle tension, sleep disturbance, causing clinically significant distress and or impairment in social, occupational, or other important areas of functioning. Etiology. Biology. Heritability is small but significant. There are different pathways, and it seems to be associated with the gene expression of neurotransmitter actions, okay, and overactivity of brain regions. The specific part of the brain associated with worrying, generalized anxiety disorder is the prefrontal cortex, okay, which modulates our response to threats. So it's got to do with cognition, prefrontal cortex, okay? Greater activation than in control. So remember, anxiety, worrying, prefrontal cortex. Okay, dysfunctional thoughts and beliefs, lower threshold for uncertainty. You think worrying is a strategy. If worrying is a way of thinking things through and getting control, and if I don't worry, bad things might happen. But you also have negative schemas. So even things that are neutral or positive or uncertain, you interpret as a threat, and then you worry. You try to get control of it through thinking. Okay? And you may even be worrying about worry. It affects twice as many women as men. Anxious mothers, so there is modeling involved, being bullied, and high stress. Okay, so you have a lot to worry about, which is why it's higher in people who are discriminated against and who are poorer. Treatment: benzodiazepines and antidepressants, but of course benzodiazepines are highly addictive. CBT is very effective. Identify your worries and thoughts. Decide, is this worry useful or not? Can I do something about it or not? Have I reached a working action plan or not? Okay. Evaluate your beliefs and look at evidence for them. So you take it out of the back of your head, put it in the front, put it down on paper so you can think it through once and for all. Develop self-control skills to monitor and challenge irrational thoughts and replace them with more positive ones. So you're getting control and you're getting accuracy. So you don't need to worry, you can think more usefully. Okay, and also using muscle relaxation, so you're addressing the physiological state of the body. Obsessive compulsive disorder. Obsessions. Persistent anxiety-provoking thoughts and images. Compulsions are an overwhelming urge to do something to counteract anxiety or ward off a dreaded event. So, anxiety-provoking thoughts: my mother is going to die, my mother is going to die. Compulsion: I must pray. That will save her. If I pray, she will not die. For diagnosis, these symptoms should take up at least an hour a day and cause significant distress or impairment in life activities. Onset: a quarter of people by the age of 14, so often in adolescence. So adolescents ideally should be early diagnosis and treatment. Equally common in both men and women, involving repetitive actions such as hand washing. They may not always be together, but usually obsessions and compulsions are together. They feed one another. Okay? So the compulsion is to neutralize the obsession. When I pray, I stop thinking my mother is going to die. Or not. But then the more I pray, the more I'm thinking about it, of course. So the obsession then actually is increasing. Okay, the compulsion may feel involuntary, irrational, and not in character, but the more you resist it, the more anxious you feel. Frequently comorbid with depression and substance abuse, self-medication. About a quarter of people report some symptoms without the disorder. So a lot of us have some aspect of this. Common themes: contamination, disgust pathways, errors or uncertainty, unwanted impulses such as thinking you're going to do something bad. I'm going to crash the car, I'm going to crash the car, I'm going to crash the car. Orderliness. Hoarding disorder, when you hang on to things regardless of their value. You can't bear to get rid of them, you think you need them, and you accumulate so many that your life becomes dysfunctional. Distress or impairment in activities. Quite a lot of people, up to 1 in 20 people in the US, body dysmorphic disorder. This you see amongst people who go for constant beauty therapy, constant cosmetic surgery. They feel like they are ugly or revolting or disgusting. Then there's repetitive behaviors, comparing your appearance to others, significant distress or impairments in life activities, often underdiagnosed because the person believes the solution is to fix their looks, not to fix the disorder. Some people know they're being irrational, but other people have very strong delusions. Trichotillomania, hair pulling disorder, pulling out big chunks of hair from the scalp. Now there's 10 times greater prevalence in women. That's a real outlier. That's amazing. Okay, and it's often comorbid. Excoriation, skin picking, you end up with tons of lesions and injuries and scars and scabs. Okay. Causing significant distress or impairment with repeated unsuccessful attempts to stop. Often comorbid with body dysmorphic disorder and trichotillomania, which is the hair pulling. Okay, etiology. There may be different disorders all masked under the terminology of obsessive compulsive. There's strong hereditary. Okay, so part of the brain involved in OCD, O for obsessive, O for orbitofrontal cortex. So you know it has to do with thinking. And the orbitofrontal cortex tells the brain that something's wrong, something needs to be fixed, something needs to be done. Okay, so it triggers us to take responsibility for things in a healthy situation. There's lower activity in the caudate nuclei. So there's different subgroups for genetic and biological markers. There may be reduced availability of serotonin and glutamate in some people. So some people respond very well to serotonin reuptake inhibitors, selective reuptake inhibitors, and others not. Okay, and they don't respond to other anti-anxiety meds. So the orbitofrontal cortex, SSRIs, caudate nuclei is down, and there may also be a glutamate deficiency of that neurotransmitter in the brain. Okay. Lack of trust in your own performance. Impulse control conflicts. You're trying not to indulge in the impulse to wash your hands again or to pick at your hair again. Okay. Compulsive behaviors reduce anxiety, and this creates conditioning. Cognitive disorders. Exaggerated perception of harm. My mother might die if I don't pray. I must have control. I can't handle not knowing if she's going to be alive or not the next day. Searching disconfirmatory bias, where you're looking for evidence that you didn't do it properly, didn't pray properly. And if you're a hoarder, you might feel responsible towards your various possessions. Okay. Sociocultural dimensions. Okay. Low parental warmth, high control, high criticism. So the orbitofrontal cortex is going, I must have control, I'm responsible. Discouragement of autonomy in the child. I'm not in control. This gives rise to maladaptive beliefs regarding personal responsibility. Most common amongst the white people in America, and also people who are divorced, separated, and unemployed. So social isolation, social disconnect. Treatment. SSRIs only help about 60% of people and only a small handful adequately. Behavioral treatments combine exposure, either gradual or flooding, okay, with the most stressful option. Response prevention. So you get exposed, you don't respond. I think about my mother dying, I don't pray. Okay. Think about attending a funeral. All right. Involves education about OCD, exposure and response prevention. Why would I want to think such terrible things? So that we can stop praying all day. Okay. Development of an exposure hierarchy, ranking from least to most feared, so that you have control and you have understanding. You've got a framework for it. Exposure until anxiety goes down. It has about a 70% success rate in obsessive compulsive disorders and good results in the others. But hoarders often don't want to let go of their stuff. They'd rather leave treatment. Okay, so good luck. We've reached the end and hopefully see you next week. All right, thanks. Bye.